All right, well, this is week 2 of our Justice series podcast. We are tackling 5 issues, 5 areas of injustice. We're talking about justice for the unborn. That's the first segment. We're doing 3 episodes of that. And then we're going to go to justice for victims of human trafficking, and then justice for the hungry, justice for the foreigner, and justice for the fatherless. So those are 5 issues that we believe are close to God's heart. They are not the only 5 issues close to God's heart, but Tom and I decided to just zero in on those 5. We're spending 2 to 3 weeks on each one. And like I said, this is the second episode tackling justice for the unborn. We're going to do one more next week. In this episode, we're introducing an OBGYN. Dr. Tom will introduce her and get into it, but she's going to get into some medical things. And I got to tell you, some of it's going to be hard to hear, but I want to encourage you to stick with it. It's important to understand what goes into an abortion, the different types of an abortion. It will be tough to hear. This is not meant to shame those of you who have had an abortion. It might be extra difficult for you. And I know there's women in our church who have had abortions. I know of at least 3 who have told me, and there's others, I'm sure. And in fact, one of the things we need to do a better job at that we get into in this episode is, as a church, we need to do better at not shaming, and making sure women don't feel shame, but rather feel safe, admitting that they're pregnant, admitting that they've been down this road, so that there can be healing, so that there can be forgiveness, and so that there's less shame around it, so that there's more conversations. It's more out in the open, and the church can be seen as a safe place for women who, especially women who are pregnant and considering abortion, but even those who have chosen to have an abortion. There needs to be healing, and there needs to be grace, and there needs to be forgiveness. So we talk about that in this episode. Next week, in the last episode for this particular issue, we have a gentleman sharing his personal story. So today is more informational and some tough stuff, and next week is I hope to be more of a human story and inspirational. So with that, Dr. Tom, take it away, Dr. Tom.
Thank you, Chris. It's a doctor's day here. So we have with us Peg Woolley today, and she is going to just start off, Peg, if you could, by telling us what it is that you do and how it is that you're involved in this fight for justice for the unborn. Where do you fit in here professionally and sort of your journey to that point?
Sure. I'm an OBGYN physician. I've been practicing for the last almost 32 years. And a little over 20 years ago, I had a patient. I should clarify, I was raised Catholic. And I came to Christ and was baptized and born again once I was actually already out in private practice. But I always knew that I wanted to be a physician. I always knew that I wanted to be to take care of women. I wasn't so sure about delivering babies, but I definitely knew that I wanted to be involved in women's health, all of women's health, not how that term has been hijacked now. And I actually volunteered when I was in high school and college for Planned Parenthood's contraception clinics, never on the abortion side, but always on the contraception side, because I saw that as an opportunity for me to sort of get my foot in the door and see what it was really like to be with women who were in need, whatever that need might be at the point. And when I was in residency, again, still attending Catholic Church, I had several experiences with abortion that cemented my beliefs that this was not something that I could ever participate in. And it became clearer and clearer that I needed to do something to step up, but I didn't know what that thing would be until I actually was in private practice and I was pregnant with my 3rd child, and I had a patient who was a volunteer at Solutions. And during the course of just our regular annual GYN checkup, I asked her, so how are you doing? What are you doing? What's new? And which is what I do with all of my
Peg, just for people who don't know, Solutions is a pregnancy center in Red Bank, right? That's
correct. We're in Shrewsbury, and we're Solutions Pregnancy and Health Center. So we are like a counterpart to Open Door. And I thought that was pretty amazing. I didn't even know that such a place existed. And shortly after that, I had a visit. So we had a long conversation about what was going on at Solutions. And shortly after that, I had a visit from the center director, again, sort of like Missy's counterpart, who came and sat in my office and told me that they had been praying for a physician to come on board and to be part of the center for a very long time. And would I consider being a part of that ministry and a part of that? And by this time she's crying and I'm crying, because this was an answer to prayer. This was something I didn't know that even existed. And now this person was sitting right in front of me asking me if I would participate. So that was over 20 years ago. And we've evolved as a pregnancy crisis center a great deal over time. We were initially just doing ultrasounds for crisis pregnancy, and our center expanded into an actual medical clinic. We're the only Christian pregnancy center that actually went to the state and developed policies and procedures and protocols to actually see patients and do STD screening and treatment, along with all the other things that we do at Solutions. So my role there is a medical director. That's what I do sort of on the side. And of course, my main job is just private practice OBGYN. And I consider myself, I'm just a regular in the trenches every single day doctor, seeing women, 20 to 30 women every single day. And there's not a day that goes by that abortion in some way doesn't play into that conversation, doesn't come up or have a role in my day in some fashion.
One thing I wanted to touch back on, and thank you so much for what you do at Solutions and everything. These are great facilities to have. But you had mentioned earlier in your intro how you had decided very early on that abortion as an OBGYN was not something you wanted to be any part of, which is, a big part of the profession in some areas. So what exactly was it for you that made you certain that you did not want to be a part of that? Was there a particular aspect of it that was the deciding factor for you? What tilted you in that direction?
Well, first and foremost, we take an oath when we graduate, as do no harm. And for me, just down to basics, when you are looking at an ultrasound screen at a fetus with a heartbeat, and then you eliminate that heartbeat, that's doing harm.
Seems like the ultimate harm.
Right. Seems like the ultimate harm. And that was pretty simple for me. And then, as I said, during my residency, I had several occasions to be, I don't want to say forced, because that's probably too strong a term, but I had requirements of not performing abortions, because that was not, I basically objected to that up front, and they said, fine, if you're not going to do the procedure, you need to be in the room. You need to participate in some other fashion. And so that, for me, that meant being present and watching the horror of various trimester types of abortion procedures. For example, my job, because I wouldn't perform the suction aspiration, at 12 or 13 weeks, my job was what I was directed to do was to take apart the specimen bottle and make sure all the fetal parts were there, reconstruct the fetus.
Oh, jeez.
Right. And when I was a brand new first-year resident, I was doing a maternal fetal medicine rotation with the perinatologist, who's the specialist in high-risk pregnancies, who at the time was also the only expert in second trimester abortions. And he was doing a labor induction abortion on a Down syndrome baby. And I was required to be in the room, and I didn't know what was going to happen. I'd never seen this before. And this Downs baby was probably 22 or 23 weeks gestation. And the baby was, when the baby was delivered, the baby was wrapped in a surgical towel and just kind of put to the side. And when I went over and glanced at the baby, I realized that the baby was alive. The baby had not yet succumbed. So I took the baby and into another room, and being Catholic at the time, baptized the baby and just stayed with the baby until the heartbeat stopped. And that was it. That was, from that moment on, it was sealed. My fate was sealed. I could not ever see abortion at any point in pregnancy as anything else aside from taking a life.
Wow.
To understand, when at the time a born alive baby during an abortion, was their obligation to try to resuscitate or do anything of that nature?
There was none. The protocol was to take the baby, wrap it in a surgical towel, and believe it or not, put it in the dirty utility room, which is where they scrub dirty instruments after a delivery or a C-section, and then deal with it later.
Really? Just let it die in the utility room.
Yes, that instance, the baby was pre-viable. The baby was before 24 weeks, but nonetheless, the baby was born with a pulse.
Yeah.
I've also had the horror of seeing partial birth abortions, which, again, not something, you can't unsee certain things once you see them. So it's just not, it's the taking of a life. For me, it's the taking of a life, whether we're talking 5 weeks or 24 weeks.
Yeah.
And it sound like just, experiences that you would think would shake anyone who saw them. And to that regard, if you wouldn't mind, would you mind taking us through the different types of abortion that are performed at the different stages, and just giving us a basic description of what happens, just so that everybody can understand, starting from medical abortions through, suction abortions and later term abortions. What's the actual process? Because I think the details will really help paint the picture that you've had to see.
Sure. So medical abortion is newer to the repertoire, shall we say, and it involves a patient who doesn't desire their pregnancy to actually go to a doctor in the office, a clinic, or a hospital scenario. And the first medicine has to be dispensed in that facility. You can't get it, you can't prescribe it, you can't get it in a pharmacy. And the first medicine they give is called mifepristone, which is a hormone blocker. The hormone progesterone is what's required to kind of glue the fertilized egg to the uterine wall. Let's just say that. It's like a physiologic glue. And without progesterone, that wall, that attachment, that glue breaks down. So that's step one. You go to the clinic, you take your mifepristone, you're right there on the spot. You're sent home with another pill, which is Cytotec, which essentially brings on uterine contractions. And you take that second pill when you get home. So now you've unglued the attachment of the fertilized egg and the zygote, or whatever embryo stage you're at, to the uterine wall, all the way up to 10 weeks, by the way. This can go all the way up to 10 weeks when we're talking about a fetus that has arms and legs and hearts and brain and all their major organs already formed. They're just tiny. So now this fetus is unglued from its attachment, and the uterus starts to contract, and it will cause the fetus to be expelled. This is not an easy process at 6 weeks, and it's a horrific process at 10 weeks. It involves terrible cramping, horrible pain. Any woman that's ever gone through this process would not describe it as anything except awful. Any woman that's ever gone through a spontaneous miscarriage is the same exact process. It's painful. It takes hours of pain, heavy, heavy bleeding, and it's scary. And when it depends on the gestational age, there's a certain percentage of women who will not expel all of the tissue. They'll expel the fetus, but not all of the placenta. They continue to bleed significantly, wind up in the emergency room, and they have to have a D&C or an aspiration procedure anyway. I just had a patient in the emergency room this week who presented exactly that way. And by the time we got her to the operating room, to evacuate the placenta that was left, she lost so much blood that we had to give her 2 units of blood and keep her overnight, until she was stable enough to go home.
So to medically be clear, we're not talking about preventing implantation here. We're talking about detaching an already implanted growing, baby at whatever stage it's at, and then forcibly expelling it. Correct? Just to be clear for those watching.
That's correct. And again, that can be done all the way up to 10 weeks. Prior to medical abortion, the only option really was to have a suction aspiration procedure performed, which would usually be done somewhere after week 6. And suction aspiration involves taking a hollow plastic curved tube that's about this long. And after a woman has had her cervix dilated, which is also a very painful procedure, by the way, and you require a pain medication either intravenously or a block, a lidocaine type block in the cervix, sometimes with some cervical preparation starting the night before to get the cervix to start to dilate. They actually use laminaria, which look like little matchsticks that if you've ever, they're basically made of almost like seaweed material that absorbs moisture. So they start out being the size of matchsticks, and they absorb the moisture from the cervix, and then they expand and dilate the cervix the night before the patient comes to the hospital or the clinic for the evacuation procedure. So the aspiration procedure, the cervix is dilated, the tube is inserted, and it's attached to suction. And in the hospital scenario, it's a big machine, and there's another tube that's attached to the big machine, and you turn the suction on, and you twirl the tube that's inside the uterus until the tissue breaks down, and you can see the pregnancy tissue coming through the tubing, going all the way into the machine. Depending on the gestational age, you can actually sometimes you see the sac fluid break, and you feel that pop when that happens, and then you see fetal parts coming through, and then you see placental tissue coming through.
So there at points you're actually suctioning identifiable human body parts through a tube.
Yes. Depends on, again, gestational age. Mind you, this is not a procedure without potential complication. Pregnant uterus is very, very soft and mushy compared to a non-pregnant uterus. And the potential for complication, especially with bigger uteruses, is that this uterus is so soft, you can't feel the border with the uterine wall, and that tube will go right through the uterine wall and perforate the uterus and create other problems, such as more hemorrhage, damage to, other adjacent tissue. For example, I was on call in the emergency room one day, and I got a transfer from Planned Parenthood where the abortionist had perforated the uterus and small bowels coming through the uterus into the vagina. So I think those things are rare, but the incidence is not 0. If you're that person, your risk was 100%. So, the other potential complications from aspiration, although on the low percentage side, are infection. And if the procedure is done even with perfect technique, although I hate to use that term, it can induce scarring inside the uterus, which makes future pregnancy and future fertility and achieving pregnancy very difficult. So that's the aspiration procedure. Then you go, and that's categorized up to week 14.
And then a later term surgical abortion would include what?
A later term, you can aspirate, you can do a D&E, dilatation and evacuation. Don't you like the term? We're going to just evacuate your uterus. Mm-hmm. Dilatation and evacuation can be done up until week 20, but at week 20, the baby has significant bulk, especially the skull. We have bones now. We have humerus, we have femur, we have pelvic bones. So typically if someone is 16, 17, 18, 19, 20 weeks, again, it has to be done by someone who only does this or does a lot of it, because it's such a difficult, risky procedure. And you don't just put a tube in it first. You have to put forceps in, and they're long instruments, and you're basically going in with these long crushing instruments to essentially dismember, take apart limb by limb the fetus, take the large parts out with these forceps, a lot of times with ultrasound, looking at, for safety purposes. And then for the placental tissue, once the baby's been dismembered, crushed, and brought through the cervix, now you do the suction procedure to try to get the rest of the placental tissue out and whatever small parts you didn't get. And that's when you have to have someone to reassemble fetal parts to make sure you got 2 legs and 2 arms and a spine and a calvarium, and that you didn't leave anything behind. And the risks of perforation and hemorrhage are greatly increased with second trimester suction procedures. So there are some doctors, abortionists, who came up with a DNX procedure. Well, they've learned how to dilate the cervix so much, and then they rotate the baby so they can pull the baby out feet first, intact, like they're actually doing a delivery, breech delivery. And this is the type of a partial birth abortion that I had to witness. They basically stick scissors into the base of the skull here and open the scissors so that they can then crush the skull so that it will be small enough to fit through the cervical opening. So it's gruesome. It's absolutely, positively gruesome. And, no one wants to talk about it. Nobody wants to in polite society, so we've come up with these terms like evacuation or intact evacuation. So, and then last but not least, we have the induction, the labor induction. So if someone, believe it or not, and there's only 27 states that put limits, gestational limits on abortion. I was shocked to learn that. I didn't know that. In New York, for example, you can't have an elective termination of pregnancy after 24 weeks. You can in New Jersey, and you can in many other states. So if you have a late second, early third trimester abortion procedure, it has to be done as a labor induction, where we actually give you drugs, just like we would if we were trying to induce labor. And the baby's actually delivered intact. And you better hope that baby succumbed and became a demise before that baby was born. Because if not, now you're talking about a baby being delivered, potentially still alive. And after 24 weeks, even though it's legal in the state of New Jersey, I don't think I've ever worked in a hospital or with a staff that wouldn't call for resuscitative measures on a baby after 24 weeks that was being born alive. So.
Thank you for taking us through that. There was some, I think it was important to really get the reality of what goes on at these various stages, and the very sad reality. Just going to go over some of the developmental points to talk about the babies to which we're doing these things.
Sure.
All right. If you don't mind, Chris, anything from you, or are we good to go on to that?
No, I'm good.
Okay. So if you don't mind, I'm going to share my screen for a second.
Sure.
As you were just pointing out the different procedures that are done at different times of gestational age, and thanks for sharing your knowledge on that, Peg. Much appreciated. One of the things that a lot of the advocates for abortion will put forth as though it somehow makes it better is that most of the abortions are done early. It's, they point to statistics like this, looking at 2/3 being done by about 8 weeks and 88% occurring in the first 12 weeks of pregnancy. Again, as though that somehow makes it not killing a baby, but regardless, these are the facts that are frequently put out by abortion advocates. So I just wanted to go over the reality of what we're actually doing here, even at 8 weeks, the early mark that they put for most of the abortions. And you can correct me if I'm wrong, Peg, but at 8 weeks, this baby will have had for several weeks a beating heart, starting at about 5 to 6 weeks. And it's easily audible on Doppler by 8 to 9 weeks. Baby already has a developing brain by 7 weeks, arms and legs by 7 to 8 weeks, which are already forming fingers and toes on them. Primitive eyes and ears already formed. Lungs are forming. The sex organs, determining if you're having a boy or a girl, are going to be forming by about 8 weeks. And generally, organogenesis has begun. I mean, the forming of all essential organs have at least started to form, if not formed, by that point. Would that be an accurate assessment of the 8-week developing human?
Yes.
Okay, so even when we're talking about the earliness, so to speak, of these abortions, we're talking about beating hearts, developing brains, arms with fingers and toes on them, a human by really any measure.
I always point out to my patients that, because they're so astonished still when they see their first ultrasound, even if it's at 6, 7, 8 weeks, I'll say, listen, all the organ systems are already in place. They're there. All they have to do is grow.
Yeah, that's a good point. Really, all the essential organs, baby has, lungs, right. everything that we have, it has in an early stage. And this is what that would look like at about 8 weeks. And, generally that appears to be a very small version of a human by any observation. And then at 12 weeks, we say, 88% are done by 12 weeks. This baby's even further along. At that point, the genitals are well differentiated. The limbs can move. It can even make a fist. The baby can make a fist at this point. They're already starting to develop some facial features. The heartbeat is easily detectable at this point. The skeleton is forming. These bones are starting to form. The baby has its own circulation system going through its body. And at this point, it can respond. It has reflexes intact and can respond to touch. So it's starting to even get some of the functions that we have in our state. So would this be an accurate portrayal of the 12-week developing baby that many of these abortions are performed on?
Yes.
All right. Thank you for confirming that. And this is just sort of a mock-up of the progression of development. On the left is just renderings of the different weeks. And on the right on my screen, that's a 3D ultrasound of what the baby would look like at 12 weeks. And you can clearly see the limbs, the hands and feet, the genitals forming there. So when you have something that looks like this, for me, it's hard to deny that's obviously a human. Do you find that has the same effect on your patients?
It's a tiny human. There's no doubt about it.
This is just talking to what you were speaking of about gestational age limits that different states have. And this was, I think, 2018, 2019. Take note, all those first trimester restrictions, none of those are actually enacted yet. They've all been held up in the courts. So a lot of those states don't actually have restrictions that early. But you can see on to 22, 24, and 25 weeks, there's still plenty of states allowing elective abortions at that point. And in certain circumstances, which have been expanded in multiple states, including Virginia and New York, and set to be in New Jersey, we can talk about that in a little bit. Abortions are allowable beyond that point for the preservation of the life and or health of the mother, which in that definition of health keeps getting expanded. Just wanted to see, and this is just a representation statewide, like you were talking about. Some states don't have specific limits as to when these abortions can occur, and others have limits of viability. Can you explain the designation of viability to those watching?
Sure. The definition of viability is a fetus that when once born can survive. Can survive basically with assistance, and the definition and become intact humans. So the definition has been changing with our advances in neonatology. So the care that we can provide to an extremely premature newborn has changed over time too. So we're pushing the definition of viability backwards constantly. So it used to be, it was 28 weeks and then it was 24 weeks. And now sometimes it's 23 weeks and 22 weeks. Now, not to say that there aren't tremendous challenges with resuscitating and keeping a 24-week baby alive, but I would venture to say that if you went over to my hospital right now, there's probably at least one or two in the NICU that have been born at 23, 24 weeks, and we are doing everything we can to keep them alive.
Tom, could you put that map back up?
Sure can. Give me a second.
You guys are both doctors. Some of this went over my head. So just so I'm clear, the states that say viability on them, that means that there are no restrictions until viability, until the baby's viable, yeah. And then the restrictions kick in.
As I understand this chart to represent, the restrictions for elective abortions. The mother can choose to have an abortion for whatever reason, and at their definition of viability.
So California has more limits than New Jersey.
Technically, yes. Yes, they do. New Jersey has very few limits on abortion. And we can actually transition to that right now, since that is our state. So New Jersey does not, to my knowledge, have a specific gestational age limit. Peg, is that correct?
That's correct.
All right. And we put this slide up last week about New Jersey not having many state-level abortion restrictions, including minors requiring parental consent to seek an abortion. So this is just, again, to reiterate that New Jersey is a very abortion permissive state. And to that end, this is just it was really a staggering quote that I saw come up recently. This is from an NPR article talking about the time when Amy Coney Barrett was being nominated to the Supreme Court, and the concerns that it had for abortion activists, getting concerned that Roe v. Wade could potentially get overturned. And the quote they attributed to our governor was, "I hope to God that doesn't happen, but we won't take a chance that it could happen." So our Governor Murphy is actually hoping to God that there's no restrictions on aborting unborn babies. It's an interesting perspective to take on that. So I have one more thing on New Jersey abortion law, but Peg, if you wouldn't mind, could you just sum up the abortion restrictions as you know them in the state of New Jersey?
Well, as you said, there's no gestational age restriction. The only thing that exists in current guidelines and law is that, number one, abortions be performed by a licensed physician. That, number two, if it's more than 14 weeks gestation, it be performed in a hospital. And then, depending on the gestational age, that there be appropriate post-anesthesia, appropriate anesthesia, recovery measures, and safety concerns and cleanliness and that kind of thing. But that's about it. And I'm sure we're going to talk about the new legislation, but right now the New Jersey Board of Medical Examiners is the one that sort of has these recommendations, and they're the ones that sort of have put them forth. So it's a physicians board that has overseen this up to this point.
Gotcha.
Yeah. And that is a good segue into the next topic. Are you familiar with the proposed Reproductive Freedom Act, otherwise known as NJS 3030?
Yes.
The proposed law, which was put forth in October, I believe. All right. Yes. Okay. I'm going to, again, go back to sharing the screen and just highlight some of the points as I've been able to find out about them, and we can discuss those in a second. Share. There we go. All right, you guys can see those again, the Reproductive Freedom Act.
Yeah.
So I thought one of the early statements in the act kind of tells you what you need to know about the focus of the lawmakers as it applies to abortion. And that's the top line that I have there. This is actually from the text of the bill itself in section 4C, where it states a fertilized egg, embryo, or fetus shall not have independent rights according to the laws of this state. So they're coming out and saying very clearly that an unborn baby has no rights in this state. Is that a fair assessment of their outlook on it, Peg, in your estimation?
Yes, absolutely. That's the crux of the matter.
Yeah. So in addition to that, it serves to remove the conscious clause for healthcare providers. Is that something that you've been advised of?
Yeah, and of course that's especially, that conscience clause has always been tenuous, but year after year it's being upheld. But this will codify into law. Again, as you said, I think our liberal governor was fearful, and abortion activists were fearful that if the last administration carried over into another administration and we had a conservative majority in the court, that Roe v. Wade could be potentially overturned. And they were trying to codify Roe v. Wade in the state legislature to make sure that if you live in the state of New Jersey, no matter what happens in the Supreme Court, that these are the laws of the land in New Jersey, that anybody can come here and have an abortion up for any gestational age. And as you said, the egg, embryo, or fetus has absolutely no rights, and that we as physicians and other healthcare providers, advanced practice providers, pharmacists, whatever, have no right to refuse to provide that type of care. And we could be censured, our license could be censured or removed if we refused.
And this is the New Jersey Medical Association that's putting this forward, that's pushing for this?
No, this is the state legislature.
State legislature, right.
But didn't you say that behind that was the
New Jersey Board of Medical Examiners?
Yes.
Right. And that's another thing that's in this Reproductive Freedom Act, is that the Freedom Act would supersede anything that the New Jersey Board of Medical Examiners decided.
So, okay, so I'm sorry, I got confused. I thought you were saying that the New Jersey Board of Medical Examiners were lobbying for this legislature.
Now they are, because they don't want to be seen at odds with the state legislature.
Okay.
But in case the New Jersey Board of Medical Examiners decided that they wanted to keep things as it is with certain safeguards, as I've outlined, this state law would supersede whatever it is the New Jersey State Board of Medical Examiners decided anyway.
Why are they so afraid of being at odds with the legislature?
Because it's one big happy family, basically. They are modifying right now. I don't know if you're aware of this, Tom. The New Jersey Board of Medical Examiners also has pending changes to their guidelines. For example, we're no longer calling an aspiration minor surgery. Now it's going to be called a minor procedure, because so
it can be done outside the hospital setting.
It's all verbiage to allow for advanced practice, nurse midwives and PAs and so forth to be able to perform these services outside the hospital.
Yeah, and that goes hand in hand with the provisions of this bill. As you see on the slide there, this permits non-physicians to perform abortions, like you're saying. Nurse practitioners, physician assistants, midwives would then be allowed to perform abortions. And abortions after 14 weeks would no longer be required, in certain circumstances, to be done in the hospital. They can be done at facilities outside the hospital. It also eliminates the requirement for an autopsy to be conducted where fetal death occurs without medical attendance. So technically, born alive babies, they don't even have to see a cause of their death, which is kind of staggering to think about. It also mandates annual taxpayer money for Planned Parenthood under Title X, and requires that all insurance carriers provide coverage for abortion in all plans. So there will not be a plan available in the state of New Jersey that does not cover, abortions. That would be a mandated requirement. And even built into the language of this law is that any future laws that would contradict this are basically not allowable. So they're trying very aggressively to push forward these items. And vastly expand abortion in the state of New Jersey. So what is preventing this from being the law of the land already?
Well, you're right. The majority leader in the state legislature who sponsored this bill has deep ties to Planned Parenthood. So, I mean, essentially, we at Solutions, we're very upset, obviously, about this, and we're asking the very same question: what can be done? What can we do? And again, we're blessed to have an attorney on our board as well, who is committed to life. And we formed a subcommittee, a legislative subcommittee, with this attorney, myself, Dr. Jane Newman, and another physician from our medical board, to explore what our options might be. And there are certain, and not being a lawyer, there are certain things that have to happen before this comes to the floor. It has to go into committee first, and before it goes to committee, you can submit comments. So what we're trying to do is not reinvent the wheel. We're trying to form a coalition of pregnancy centers to form essentially a lobby on this matter. Now, we already have the New Jersey Family Policy Council, which is probably the largest lobby in the state for pro-life issues, but we need physicians to come on board as well, to be able to advise the attorneys on how to answer and how to go through these legal channels to try to object to this even getting into committee. So that's what we're doing at Solutions right now, and it's a conundrum. We feel like we're being washed over by just wave after wave after wave. But there are certain constitutional issues, from what I'm told by our attorneys, in the way this bill was put forth, that would make it very likely that it wouldn't hold up under scrutiny in the higher courts. And that I found to be very encouraging, as well as some discrimination matters. For example, why should it be that abortions are the only medical service provided with absolutely no copay, coinsurance? Why should abortion services be paid for in full, where breast cancer treatment patients, even poor breast cancer patients, have to pay something out of pocket, or whatever it is that your condition is? Why is it that this is the only carve out that will actually be paid for in full by the federal government? So there's potential for they want to codify this as a civil right as well, by the way. So it goes both into the federal court system and under the civil rights laws, as well as into the state legislature.
Yeah,
it's going to be a long battle. It's not going to be resolved, quickly. And I think there's going to be a lot of time.
It seems like it's an uphill battle.
Yeah, it's going to be an uphill battle. And I think there's going to be a lot of time for response. Our job, as a church, as a medical community, is to have an intelligent response, which is what we're working on.
Very good, and thank you for doing that. And just the topic you just broached about having these things considered like a fundamental right that can't be infringed or even made inconvenient in any way seems to be the direction that these legislatures are trying to take it. And in recent years, you've heard these things, especially when it comes to law, referred to less and less as actual abortion and more under various euphemisms. And things like reproductive rights and women's health in general have now become synonymous with abortion. As a doctor in the field of women's health, how do you feel about that seemingly intentional language game that's being played, and what kind of damage do you think it potentially does?
Well, it's generational, of course. I fear for the young women, the middle schoolers and the high schoolers who are being taught that women's health is synonymous with the right to have an abortion. And it's not about reducing your risk for heart disease anymore, or even quitting smoking and exercising and maintaining a healthy weight. Women's health is only about, this is my God-given right, and no one can take it away from me.
Yeah. Do you think that part of the reason that they're using like reproductive rights or women's health instead of abortion is to basically euphemize it so they don't actually have to use the term, because they know people won't be as embracing of the term itself if you,
Of
as
course.
they would if you can, sugarcoat it with a, as a right, as a women's right or women's health, because who could possibly be against women's health?
Right. Who could possibly object to reproductive rights and freedoms?
When you state it like that, when you state your cause as justice, you automatically labeled anybody who opposes your cause as supporting injustice.
Right.
In your position as a physician and as an OBGYN physician, since residency, we'll say, do you feel professional or legal pressure to perform abortions? Is it financially, are you incentivized to do it, or is it harder to make a living if you don't?
No, I would say I don't feel pressured, but I was in a unique position for a long time to be my own boss. I had my own practice. It's only over the last 4 years that I've become an employed physician, and even in that capacity, I don't feel pressured. And I think it's fair to say that the vast majority of my colleagues, even those who might be pro-choice, they don't want to do abortions. They don't wake up in the morning and say, oh, thank God, this is great, I'm going to go do 10 abortions. This is not something that anybody wants to do. Some feel compelled for whatever their reasons are that it should be part of what they do, but the vast majority of us don't want to be doing this. I don't feel pressured by it at all. It's tricky when I have a private patient that comes into the office seeking an abortion, because I try, to do mostly listen and be empathetic and just tell this person how sorry I am that they're at a point of crisis. I tried to get them to agree to let me do an ultrasound because then I know the conversation can change into something much more potentially positive. And even if I have someone who just is heartbroken but doesn't feel like they have a way out, we can still have that conversation, and we can still be available to them regardless of whatever decision they make, because they're going to need help afterwards. They're without a doubt, and the last thing I usually say to them is, look, my job is to take care of you, not just now, but hopefully for years and years to come. And this is not something that's going to go away. We're going to have to pick this up afterwards. And, that's an opportunity to offer them post-abortion counseling. My last word to them is always, I ask permission to give them some perspective. And usually they'll say, sure. And I'll say, listen, in all these years, I've never had someone come in and tell me that they regretted having a child, but I deal often, many times per day, with women that have regretted their decision to end a pregnancy. And I leave it at that. So.
I think that echoes what Missy told us in her experience last week as well, and I think that's a powerful statement to make. So before I end my questioning, and Chris, I'll turn it over to you. Peg, is there anything else you think you haven't mentioned that you can do in your professional capacity to encourage life, to encourage those to choose life, to fight for justice for the unborn? What can you do to encourage those who are in crisis to choose life?
Well, aside from using all the resources that we have outside my private office, namely places like Open Door and Solutions, I ask them when they're in crisis to just take a breath. You don't have to make a decision today. Whether you make a decision today or whether you make a decision in a week, it's not going to matter to your overall to your overall health. You're going to be, you just take a minute. I try to get them to understand that whatever the reaction, whatever the fear is, it's so intense in the few days after you realize that you're pregnant that a lot of times these young women don't stop and really consider what their options might be. And ultrasound is a wonderful tool in that regard. The other thing that I propose is, look, 1 in 5 pregnancies is going to end in a miscarriage. suppose you were going to have a miscarriage and now you're going to live your whole life regretting that you had an abortion. Give me a week. Give me a week to find out if this is going to be a viable pregnancy or not. Take that week and think about this, and let's talk again and use your resources. And if you don't have any resources, then come back and talk to me, and then come back to me in a week and we'll do another ultrasound. So I'm just offering them an opportunity to just take a pause before they make that final decision. And we could talk for another hour about this, but the medical abortion has made it so difficult, because you can buy a home pregnancy test that's reliably positive 3 days before you miss your period. And as soon as they get that positive pregnancy test, they're on the phone. They want that. They want the abortion pill. So we've lost that week or two that we used to have to interact with these young women who are in crisis before they make a decision.
And are there any ways that people who are watching, mostly members of our church and the like, are there any ways in particular think they can help you in your endeavors, such as solutions or what have you? What are the ways that practical steps we can take to help?
Well, just as Missy said, we need prayer, prayer for the young women, prayer for our center. COVID has really made an impact on the services that we can provide, and we're hoping to be able to be open again the way we were before, and see more young women. We need creative solutions. We need prayer for creative solutions for that 5 to 6 week window where we're just missing that whole piece now, where we can reach these young women. And of course, we are privately funded, just like Open Door. We need volunteers of all ilk, whether you're an architect, a baker, whatever it is, a landscaper. So those are the three things that we're constantly praying for: is to have prayer support constantly, and to have our funds enable us to stay open, and to have the volunteers that we need to stay open.
Chris, anything that you wanted to add?
Peg, what do you pray for?
Open hearts. I pray for that encounter in the ultrasound room, that these young women would, that how the hymn goes, "Open the eyes to my heart," that their heart eyes would be open to the fact that this is a living, tiny human and not a clump of tissue, and that they would see this, that they would put that in context of their decision, because it's a lot easier to decide to get rid of a clump of cells than it is to get rid of your unborn child. I want them to see this as a child.
Yeah. Do you feel like, is there any, like with the legislation going in one direction, is there any evidence of things going in the other direction? Like do you see people being more open-minded to the fact that this is life? Do you see less and less women being abortion-minded? Do you see any reason for us to have hope that even with legislation going in one direction, that the numbers are going to just drop?
Well, the numbers have continued to drop for surgical abortion, but I think that's probably because the medical abortion numbers are going up so high. I think it's a hard question to answer, because when you're in the trenches and that's all you see, you think that's how everybody is. But it's become so difficult to be a conservative pro-life physician, in the world. It's very difficult to be pro-life. We are accused of being anti-woman when you're pro-life. So I pray for that too.
Yeah.
And I don't know that I see the swing going the other way. I really don't know.
What about for churches? Is there any charge you would give churches?
I think, as Missy said, there are about 2 out of every 5 abortions that are being done are on women that are part of a church community. And I think we avoid the topic as a church. Or if we approach the topic, it can be somewhat in a somewhat judgmental way, let's say, rather than, oh my God, I'm so sorry that you're in this situation. And can we just please talk? And how is it that I can come alongside you and help? And that is the fine line that I always have to skate as a physician too, is this is your decision. I can't influence your decision, but I'm here to help you understand all the ramifications of your decision. And whatever it is that you decide, I'm here for you afterwards. And as a church, I think we need to make it clear that we're here for these women that have had abortions, so that there's no, it's clouded in shame. And if we can somehow shed the shame and let these women come forth, it's all about shame. And Chris, you know better than I do, how powerful shame can be and how difficult it is to unearth it.
Yeah. Well, Peg, thank you. That's I think Tom covered everything else.
Yeah, I just want to reiterate, thank you so much. I mean, to get, I'm a doctor, but I'm in no way in that field. So this is almost as far removed from me as it is from the medical, person who might be watching this. So your perspective is much better than I could have given, and much appreciated. And a doctor with a heart that mirrors God's heart, I think in your field particularly, is incredibly valuable. And thank you for being in it, for being in the fight for justice for the unborn, and not just someone like me from the sidelines who's talking about it, but you being in it, being on the field, and God bless you for that.
So Tom, you want to pray, close us? And
Be glad to. Be glad to. Lord, we thank you for this time to come together in your name to talk about a subject that's on your heart as well as ours, Lord. And we lift up all the unborn again, and the struggle that they face and the forces that fight against justice and their lives, Lord. We thank you for Peg and those like her doing similar work, Lord. And we pray that you continue to bless their ministries, bless their operations that they have going, Lord. Just let them thrive and continue to do the work, even when the odds seem to be going against them, Lord. Let them flourish in your name and in the work that's on your heart, Lord. And I pray for all those watching this, Lord. I pray that you would open their hearts to the message. Let them appreciate the injustice that we see and that you see for the lives of the most vulnerable among us, the unborn, Lord. And we pray that this would change hearts, enlighten minds, and enrich us and enforce our resolve to follow your heart, Lord. In Jesus' name, amen.
Amen.
Amen.